we're on. We've got blue light. Good morning. This is Kimberly Hendricks, the chair of the SEOW Workgroup, and today is May 5th, 2026. And I'd like to convene our regular meeting now. First up is our April 2026 SEOW meeting synopsis. And I will entertain a motion to accept them as presented.
One, two, we do. So OEB is
I could
enough.
do.
OEB's got enough.
Sorry, roll call. It looks like we have Andy and we have Robert, and then we have me.
2 and 2. I can't see the other names, so.
That's 6 people. If we have,
Okay, so let me do. So Greg Klauser, are you on?
We have 2 PEB and 2 OEB.
yeah,
so
that's,
it should be good.
that's 4.
We're good.
We're good.
Okay.
Sorry, yes.
Okay, good.
Just, I didn't.
Okay, sorry. I guess.
No worries. So we're good.
Okay, so the
I'll
meeting
move
synopsis.
I'll move to accept the meeting synopsis as presented.
And do I have a second?
This is Robert. I'll second.
Good morning, Robert. Thank you. Any questions or comments? All in favor accepting the synopsis as presented?
Aye.
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 Thank you. All right. First up, looks like we have dental quality utilization performance guarantees report.
Let's start with Kaiser. Do we have reps from Kaiser? Oh, sorry, didn't mean to be.
We're here.
We have plenty of time today, so.
Moving as quick as they can.
Well, you're right on time. Good morning. Can you hear me?
Yes, thank you, Dr. Pilstrom. So I am with my partner in crime here, Dr. Pilstrom. I'm Lindsay Lee Worgan. I'm the Vice President of Dental Care and Coverage for Kaiser Permanente Northwest. Dan, do you want to introduce yourself as well?
Yeah, my name is Dan Pilstrom. I'm a general dentist. I work at the Cedar Hills office, and I serve as Chief Dental Officer for Permanente Dental Group.
Perfect. And I think, Nick, are you on as well?
I'm here as well. Good to see you. This is Nick Abraham. I'm the Senior Manager for Dental Business here in the Northwest.
Fantastic. All right. So today we're going to talk about our quality and utilization performance tied to our performance guarantees. We're also going to talk about the improvements that we've made and where we're going next, and we'll share our race and ethnicity data as well. Go ahead to the next slide. All right. Do you want to go ahead?
Absolutely. Yeah. So here is the 2024-2025 reporting and performance quality goals. You can see the 2024 and 2025 for OEB and PEB listed there, and the goals. We've made target on all of these with the exception of the care gap summary. I'll kind of break it down here. So we're doing preventative services for adults for high and medium risk patients. One of the cornerstones of our practice is that patients get risk assessed for periodontal disease and tooth decay at their annual exams. And then we have calibrated our practitioners to prescribe cleanings based on their risk. It's really about trying to meet the patient and provide the right care at the right time for these patients. So 77% for OEB, 73% for PEB of high and medium risk for adults received a cleaning in those years, 63% for children, and again, for PEB it was the same. Care gap summary, we underperformed the target. This is a reminder. So we'll talk about medical dental integration towards the end of the presentation, but this is simply the practitioner or the hygienist reminding the patient of a care gap they have. And those reminder systems have changed over time. And I think that's one of the reasons why we're seeing a dip here. Diabetic care gap closure. So that's reminding, that's patient got one of 3 diabetic care gaps closed after the visit. After the dental visit, so 78 of diabetic patients who have a diabetic care gap, 78% for OEB and 75% for PEB. And then ease of scheduling, we saw a dip, significant dip in 2025, and really around the online appointing and a lot of the growing pains that we experienced with that system. Target was 74 and 76, and we hit 68% in both OEB and PEB. And you can stop me if you have questions. Otherwise, I think I'll just keep going. Yeah. So here's our race and ethnicity data. It's really important that we, when we're taking care of patients, we gotta be able to reach patients, and that means having everyone feel welcomed and comfortable in our offices. So this is important data to understand our practitioners. Do we reflect the patients that we see? Do we have interpretive services? Do we have consent forms and languages? Are we able to reach the patient in the way that they need so they can get the care that they receive and that they can take care of themselves? We've performed well, pretty consistent between 24 and 25. African American population for adults is stubbornly lower utilization. It's the same in medical. In fact, medical invested in the Kaiser Center for Black Health and Wellness, which is the North Interstate. We do have some connections with that office in our Grand location, which is the nearest dental office. But that group remains a little bit below some of our targets. Other groups that are below, like Pacific Islanders, you'll notice in the chart to the right it says insufficient sample size. So it's really hard to understand how significant that is. Okay, next slide. This is our children. Pretty consistent results. And again, the ones that mostly are big differences, like American Indian, Alaskan Native, you can see on the right-hand side, there's very small sample size. So I think that oftentimes explains big differences, but I think it's fairly stable utilization. I think the trend is increasing utilization in 2025 here for children. And the next slide is PEB, adults. Similar patterns. For PEB, Pacific Islanders are really small group, as well as American Indian and Alaskan Native. And for children for PEB, next slide. Again, big swings in some of these smaller groups, but pretty consistent utilization across these different ethnicities. And the final slide on race and ethnicity is care gap closure. And here's where you see really wild swings because the number of patients that are coming in that also have diabetes is quite small, thankfully. So we do see wide variation from year to year in these because of that. Are there questions about the race ethnicity data?
Have you surveyed some of this to understand, like, is it education? Is it, have you done any kind of deeper analysis on this?
Yeah, not really by race ethnicity, but we have looked at Medicaid populations and older adults across all races for things like transportation and social determinants type measures that you'll find that medical does. But it doesn't link exactly back to this. So no, I guess the answer is we really haven't been able to collect data like that.
Well, so Dan, there are a couple things we've done, and this is some of the value of being linked with medical. We do have a Black patient advisory group. We also have an Asian American patient advisory group. So we are standing up specific groups to understand, is it an access challenge? Is it an engagement challenge? So we're able to use those forums to help inform some of these gaps. So it's not specific to dental only, but it is part of the broader medical dental picture.
That's a good point. Thanks, Lindsay.
Points that, on that social determinants kind of thing. I mean, I'm in the largest bar here and I hate going to the dentist personally, right? But yeah, it's just, is there an education component or is it a transportation or time or, is it their
behavior, right?
Where's the income brackets change? That's kind of hard to determine, right? But they're all factors in this.
Right. And even hours of when appointments are. If we're talking about, a group that really can't come in during the working day, thankfully we do have Saturday appointments. We have evening and morning hours as well, but these are all factors, right?
Does your new facility on the Interstate Avenue, does that have dental?
So the Interstate, the Black Center for Health and Wellness does not have dental integrated into the actual office. The operatories, the grand office is about a mile away. So we are able to connect members. Yes, and we're able to coordinate that care. Mm-hmm.
I will say one thing that really does, I think, differentiate us because we are connected with medical. They have a lot of requirements around interpretive services and multi-language capabilities. So we have like either in-person interpretive services or we can dial in a video conference with an interpreter, which is very, very helpful as a dentist when we are trying to communicate with our patients who don't speak or are not comfortable speaking English.
In a variety of languages. So we're really able to extend the care in a better way because we have that. We're able to bridge that language gap.
I was kind of thinking of some math here to try and normalize based on the sample data, but it's hard. Because I mean, I get you that some of these numbers, especially Pacific Islander numbers, are so small, it swings the bar way around, which makes it hard to interpret. So there's got to be a way to normalize that, but I'm not sure how. But anyhow, enough for me.
If you have ideas, send them our way because you're grappling with that.
Yeah. If I think of something, it's on.
Okay.
I know who to talk
So this is Dr. Lara. I have a question, follow-up for Daniel. So do you have any demographic data like age group and, I don't know, gender, something like that to share? Not today, but to share eventually.
Yeah, we would have that data. Yes.
Okay. And then also I just want to make a comment. No, because you have interpreter services, you know that the patient is going to be, or the member is going to be really aware about the healthcare system. So that's also health education. So I just want to make that a note. Thank you.
All right.
I think you're up next, Lindsay.
All right. I'm not sure who is.
Yeah.
Oh, perfect. Okay. Access. So clearly in the data, we're looking at ease of scheduling, looking at access, and that has been our biggest focus and continues to be a significant focus. We've made huge strides that we're very proud of. So some of our talking points, we're adding hygiene. So we've added additional hygiene resources to our Salem and our Hillsborough offices. We're adding more this year. We currently have 35 positions that we're actively recruiting for, 20 additional hygienists and 15 additional assistants, which support both our dentists and our hygienists to provide excellent care. And that will be the expansion across the PDX Metro. It really goes across the entire region. We're adding pediatric dentistry to the team. We've increased capacity by 25% by adding a pediatric dentist to our Tigard office. And we are actively recruiting for another pediatric dentist, likely located on the East Service area. So that will significantly increase capacity. We're also partnering closely with our general dentist team. So kids that are really ready to graduate out of pediatric dentistry and into general dentistry, we can get that care well coordinated as well. So these are all plays at really improving the scheduling and access experience of our members. We continue to collaborate closely with Pacific University. It's a significant pipeline for us. We're helping to train hygienists and assistants. We take teams of ours. One of our labor partner, our hygienist labor partner, goes and is one of the educators at Pacific University. So we're really investing in the future of the program. And tied to that is the dental therapy program. So we have one dental therapist located at our Valley River, our Eugene office so far. This is a program that really has struggled to get kind of the momentum behind it. So we're really working with the universities to try to move that forward, which would then create a mid-level dentist. Think of it like a nurse practitioner, which can provide much more of that routine care and help to ensure our dentists are working to top of scope. So in the last year, on the kind of the bar chart there, we have added 12,000 appointments from 24 to 25. That number will increase this year as we are investing back into our staff. I did want to call out, whenever I say significant investment in staff, the first question I get is, well, how is this going to impact my premiums? It's not, because what we're doing is we're looking at all of the spend. We're looking at our write-offs. We're looking at facility expense. We're looking at administrative overhead. How do we shrink that and take those dollars and put them back into staff? One tangible example of that is we closed our North Interstate office last year. We moved all of the staff, facilities, it all moved to other nearby offices. So we didn't lose any capacity, but by doing that, we saved $400,000 in annual expense that it was costing us to sustain that building. I took that and flipped it into more hygiene FTE. So we're really looking at how do we just fundamentally improve our business model to increase, we need more people cleaning and fixing teeth, and that's what we're focused on. Okay, and then the last kind of factor on this one, 98% of members with urgent emergent needs are seen same day, next day. So we really focus on both the routine experience and that urgent emergent to make sure we get both in. Okay, let's go to the next slide.
You have a program for your dental employees to get education, move up? Do you have a sponsorship to help them move up?
Yes, we do. Very robust. So we have both from assistants wanting to move into hygienists. We even have an LPN. So in our integrated offices, we have LPNs. They are actively, many of them are pursuing their RN. All of that's supported. We also support all of our management teams. So right now, 60% of our office managers are all pursuing additional education, which all is great and all supported by Kaiser Permanente. So we do it in a variety of ways. Yeah. So some things that we've done in the last year to make it easier to get care. We have really focused on this issue of you can't find anything online, so you're calling the call center. That doesn't work for anybody. What we've done is we've changed our actual template build, so you have many more options to book into the schedule. So instead of saying you only get to book at 9 a.m. XYZ days, you now can book any hour of the day, and we have far more available appointments that meet your need. We've also changed our transfer policy, so this idea of you can only book an appointment at one office, we're going away from that. We've gone away from that. For routine care, you can select any of our dental offices and get that appointment, which is a really expanded choice for members. We have redesigned our online scheduling experience to make it easier to get that care. And what we've seen is an increase from 15% successful online scheduling to 35%, and that number is increasing. Conversely, we're looking at our call center as well, and we've seen a 30% reduction in calls going to the call center because we were able to get that need met at that first call. The other piece we're working on, so we've expanded our template so you can now book in the next 18 weeks. So from today, 18 weeks out, which is 4.5 months, that's our scheduling window. We are testing right now a 6-month option for pediatrics, and we're building out. So we'll be piloting at one office, working with those nuances, and we're going to be piloting a 6-month appointing option for adults. Both pediatric and adult 6-month appointing will be based on your risk score. So Dan touched on that earlier. We are really focused on value-based dentistry and ensuring you're getting that care when you need it. Might be every 3 months, might be every 4, might be every 6, might be annually, and that's based on your dental risk score. So if it is 6 months, we want to have an option available, and we're testing that out now, and then we'll be scaling it once we figure out those nuances. Dan, anything you want to add in there?
Yeah, I will say that all of these things have really already made a difference. So at the beginning, I talked about the end of 2024, 2025 reporting time, the ease of scheduling was 68%, good, very good. And currently in Q1 of 2026, it's 74%. So these changes that Lindsay and team and the whole crew have made have really helped move the ball. So I'm optimistic for the next reporting period. It's going to be much better.
Yeah, and we'll also share, so far, we've seen a reduction in our access-related complaints and grievance, former complaints and grievance. They've reduced 70%, and that number is increasing month over month. So we're really seeing dramatic improvement, both in our ease of scheduling scores and then in our overall experience scores for the program.
Do you contract out dental surgery, or is that in-house? And if so, how's the access on major surgery, like
I don't have
screws and things?
It's a great question. Dan, do you have the access number? I don't have my access number on our oral surgery in front of me.
For specialty access, I don't. But again, it is also it depends on the urgency of the surgery that's needed. For example, if you need routine third molar extraction, you're asymptomatic, it's just time to do it. It's going to be a longer access period compared to patients that are actively having symptoms. So, but that's something that we can put together if you're interested in that specialty care access.
I think that's where the longest times come in when you need a
Typically, yes.
right? So just kind of curious how that, and do you do that in-house then?
We do. There are some very small pockets that we send out. So an example is orthodontia in Eugene. We just don't have enough membership to justify bringing in that in-house at this point. So that, and then there are some very small pediatric components that we send out to an ASC, but it's very rare. We do primarily do our
So you
specialty.
have the capability if there's suddenly an emergency.
Absolutely.
Yes.
Yeah, and we can bring back, Dan, it's a great call. What we can do is bring back here all the different specialties we offer in-house and then what that access looks like and the experience scores for those. Those are areas we're looking at what I consider kind of a book of business to look soup to nuts from the time you're told by your general dentist, this is needed, how long until you get this, whatever it might be, and then what's the quality component of that. So we can
The high level kind of surgery level stuff is where we're kind of more.
absolutely. Yep, we can. Okay, let's keep going. So I touched on this already. So just really focused on, we're looking at scheduling across every department, every member interaction, and how do we improve that and improve care by starting to bring in technology. So we have launched dental digital impressions in our orthodontia spaces. That's something we'll be expanding and scaling across the program and looking at. We've got on the medical side of the house some AI pieces we're using around documentation support. It's not currently at the level of fidelity we want to see for dental, but it's something we're looking at. So how do we continue to bring in technology to improve the care that we can provide? And looking at how do we continue to strengthen our staffing models, particularly in our outlying areas, including how do we expand the diversity of our workforce is something we're always focused on as well. And as I mentioned, really, really focused on how do we keep growing the pipelines. We've got more hygienist assistants coming out of school so that we can bring them into our model. I think that's something we're all focused on is how do we have a stable workforce. Okay, next.
Personal opinion, I never want to see a robot doing gum measurements on.
Same. I'm with you. I know. But a digital impression.
Okay.
If you've had the old school one, it's
A
true.
sharp instrument going.
Fair enough. All right, next slide.
And I think this one is me. Yeah. So can't close before we talk about medical dental integration. It is such a differentiator for us. Even nationally, you won't find integrated health systems with dental and medical where they're closing care gaps in the dental setting. So this is program-wide data across the whole year. 3,700 flu and COVID vaccines provided in the dental office, over 3,000 medical appointments booked in the dental office, and over 21,000 diabetic care gaps closed. So patients who are diabetic need their A1C, they need other labs to make sure that they're well managed. And patients really love this service. It makes us different. It makes the care more accessible and convenient. And 95% of members would recommend Kaiser Dental, in part because of this type of integration. The next slide is the OEB and PEB data that I want to spend a little bit of time on. And on the left is PEB, on the right is OEB. So in the sort of upper left boxes there, 72% of PEB members and 60% of OEB members receive dental services at a co-located office. So that means a dental office where there's a medical facility, or it's either inside the medical facility or like in the same parking lot. Or there's a licensed practical nurse who can do blood draws, make appointments, etc., vaccinations in the office right there. So the majority of your members go to one of those offices, and that's great because if they have Kaiser Medical, and most of yours do, then they can receive those reminders if they're due for a care gap, and then they can actually get them closed at the dental office. And then the box just below that, for PEB, 47%, and for OEB, 49% of members had one or more medical care gaps closed over the course of the year. So that's something you won't find in other dental offices where you're coming in for a routine cleaning or a filling or whatever, and you can get a needed medical service provided at the dental office. So really proud of this work, and I think it really helps in really the overall mission, which is total health at Kaiser Permanente.
Couple
And
stories just to illustrate this and things we're doing right now. Last week, we heard a story out of Skyline. A member, a younger woman came in and told her dentist, last time I was here, you mentioned that she had a lump in her neck. Turns out she had thyroid cancer, and she came back and saw it, and she was in remission, and we were able to connect her with that navigator. So there's those really extreme, beautiful stories. And there are the stories like today, we're working with our denture services program. How do we integrate in our behavioral health support and our nutrition support at these key intersections that really change your life? That's where this is fantastic about medical dental integration, and there's so much more that we can do. So we're continuing to look at how do we evolve that program to grow it.
So does that lower right box mean you PEB members are more hardcore smokers than?
it's really hard to get the smokers that are still smokers to stop.
You weren't mumbling. Not you.
Better out of grow up, right?
All right, next slide. All right. Any other questions? It sounds like we want some data on age breakdowns, on gender breakdowns, and then more information on the specialty care services. Absolutely. Anything else we can provide?
I have a quick question for you. So you talked about this kind of new provider that's kind of like a dental NP equivalent or PA equivalent.
Yeah.
Could you just briefly touch upon what scope of services they're able to provide?
Yeah. Dan, do you want to touch on that for our dental therapy program?
Yeah, so the dental therapist is really unique. There's only a few states in the country that allow it, and it operates under a collaborative agreement with the supervising dentist. So they are credentialed to like perform a simple tooth extraction, do fillings. They're credentialed to do all types of hygiene services. And as long as that collaborating dentist is comfortable overseeing that scope of practice, they're allowed to do that. They really serve a great extender to the general dentist for routine dental care. So they're not allowed to do, for example, crown and bridge, root canal services, implant services that really do just require more scope and training.
Thank you.
Thank you so much.
Thank you.
So good to listen to you and talk to us. Andy, you've got a question.
I do also comment, I work with my students are Oregon Tech dental hygienists, and I recently found out that they are learning how to do fillings and such and really help bridge that gap. And so it's really exciting. And if anyone wants to go and spend 10 hours in a chair to let them practice, let me know. Anyway, I was really excited and they're really excited that they're able to do that. So anyway, thank you.
I'll think hard about that.
I love it. I love it. And who do we have up next?
Willamette Dental.
Oh, perfect. On screen or in person?
Sure, Christine Weinecke.
Yeah, I'm here in myself, Dr. Chambers. We're both remote.
Good morning. Welcome.
Good morning, and thank you for allowing us the opportunity to present to you today. As I said, I'm Christine Weinecke. I'm the account manager for OEB and PEB, and joining me is Dr. Mark Chambers. He's our director of clinical operations at Willamette Dental. Next slide, please. And the next slide. Thanks, Rose. So for our time today, we'll start with a brief overview of our 2025 initiatives, highlighting the key strategies we've focused on to strengthen our preventive care, quality oversight, and access. We'll then move into the 2024-2025 quality performance results, where we'll review preventive care for both adults and children, as well as oral evaluations for adults with diabetes. We'll also look at these results through different lenses, including risk level, geography, and race and ethnicity. And next, we'll cover our appointment availability performance, including member satisfaction trends, and see how our recruitment and access initiatives are supporting improvement in this area. And after that, we'll share a look ahead at the performance measures plan for 2027, and we'll close with any questions. So next slide, please. And at this time, I'll turn it over to Dr. Chambers.
Excellent. Well, thank you for being here this morning. Just want to share with you a little bit about some of the quality initiatives we've taken on this last year to, improve some of the quality metrics we have to provide better preventative care to our patients. One of the things is we're always looking at and analyzing our data and information to see where we can improve and steer the organization towards better preventative care. Part of that is, targeting. Dr. Filstrom talked about, targeting the appropriate evidence-based preventative care to the right patient at the right time. And, that's twofold. That's us delivering the care, but it's also making sure we outreach the patient, get that patient to be educated and learn the importance of doing their part and coming into the dental office. With patients that, as we reach out to patients, we reach out to them 45 days before their appointment, their recall, 10 days before their recall, 10 days after their recall if they don't show up. And then if those three efforts have not been successful, then we turn to personalized phone calls and outreach to get the patients to come in. After a patient schedules, it's just as important that they follow through with that appointment. So we have 3 different touch points with the patient after they schedule to encourage that patient to make sure they keep their appointment, come in, and follow through on care. The other thing that we have is that we've built in decision support tools into our electronic dental record. And that combined with compensation incentives for our providers, it's to steer, making sure that we're delivering that appropriate preventative care to our patients. On the next slide, I just want to touch on a little bit about where those initiatives have led. First of all, we've seen a 50% reduction in open positions in the last 24 months. We've done that by increasing our recruiting group that are seeking out good candidates to fill those roles. With that, we've hired 24 dentists over the last, in 2025, 37 hygienists and 58 dental assistants. The average wait time or average access time to get an appointment is 24 days currently in Oregon and Southwest Washington. And we've seen, we send out surveys to patients, getting feedback and guidance, and we'll talk about that more later in the presentation. But for OEB, we've seen patient satisfaction with appointment scheduling up 3%, and for OEB, or sorry, and for PEB, up 6% in 2025. For the next slide, I want to touch on these performance measures, and I'm going to throw a lot of data at you, and I hope it's not too much. If I start to see your eyes glaze over, I'll try to speed it up, and we'll see how we do. But this first measure, when we look at preventative services for adults, so adults over the age of 19, and did they receive a preventative service in the calendar year? The target benchmark was set at 68%. And you can see for OEB, we came in at 72%. And for PEB, we came in at 69% in 2025. One thing that you will notice, and as we go through the presentation, look at the data, and this is not true just for Willamette, if you look at the Delta numbers and the Kaiser numbers, is that OEB employees tend to utilize preventative services at a higher rate than PEB employees. So that's noteworthy, but we'll touch on that a little bit as we go as well. If on the next slide, you'll see that we're going to look at preventative services by adults, but then broken down into risk level. So on that next slide, you'll see right here, we have broken down to low, moderate, and high risk. So every patient that comes in for an exam, we do a full workup, x-rays, probing depths, oral hygiene evaluation, risk assessments in terms of dietary, dry mouth, other factors that can contribute to decay. And all those factors go into the risk level for that patient. And what's interesting is that one of the most challenging groups, and I think all the docs on the call today would agree, to increase compliance on are those high-risk patients. It's those patients that have disease. I think in part, a lot of that is tied to the fact that they have a history maybe of not being very compliant in the past, and or they've established, bad habits that are hard to change over time. And so typically, if you look at risk levels, we see those high-risk individuals, not always utilize preventative services at the same rate a low-risk individual will. For that reason, we actually do additional outreach to try to get those high-risk individuals to come in and receive the preventative care they have. And you look at the high-risk individuals in OEB, and we actually had a 3% increase in the high-risk individuals in terms of preventative care from 24 to 25. On the next slide, we'll further break it down by race and ethnicity. If you look from 2024 to 25, most of the groups have increased in the preventative care. The two exceptions that we'll see where we see a lot of variability, and it's interesting because it lines up just with what Dr. Filstrom said, is the Native Hawaiian and other Pacific Islander group, and the American Indian and Alaskan Native groups. You'll see huge swings in these up and down year to year, and is due to the sample size. It's just fairly small. So for example, on the OEB patients here, if we look at the American Indian, Alaskan Native, they saw a 20% increase in preventative services over last year, which sounds really exciting, right? If we look at the next slide, for PEB, we saw a 15% decrease. And again, that's just to kind of show it's that sample size that can change that so much. It's the difference between one family, following through and coming in for their dental appointments that year, or that one family, choosing not to. It can cause a huge change in those numbers. If we go into the next slide, we'll break it down to geography. And if we look at geography, typically urban areas utilize preventative services at a higher rate than rural. So we target outreach to our patients and to those rural patients to try to increase utilization. There was a group, the Rural Health Research Group, did a study looking at nationwide preventative adult services. So the same thing we're looking at here on this graph for the OEB patients. And they found that in rural communities, 56.4% of adults utilize preventative services, whereas in urban areas, 65.9% utilize preventative services. So that's about a 9% disparity in nationwide data for utilization of preventative services. If we look at our data here for OEB patients, we see that disparity between urban and rural is 2%. Still a disparity, something we want to always improve upon, but lower than the national average. And if you were to look at other studies done in terms of disparity between rural and urban, those studies typically fall within 5 to 10% decrease in utilization of preventative services nationwide in rural settings. On the next slide here, same thing looking at urban versus rural, but in the PEB population, but we only see a 1% disparity change between urban and rural in 2025. And I think the other thing to note is that these were, all above benchmark for urban and rural communities. The next question, or the next slide, will go into preventative measures on children. And with the benchmark being 74%, PEB and OEB met or exceeded both of those targets in 24 and 25. Oh, yes, please.
Question.
Oh, sorry, Dr. Chambers. I was just wondering, which of the counties do you currently have that have the extreme access concerns?
Christine, do you know what exact counties? I didn't look that up to fell within those categories.
I don't, but I'll reach out right now and see if I can get a quick answer.
Yeah, and if not, you can just provide it later. That's fine.
Okay, perfect.
If I remember correctly, and please don't hold me to it, we'll get you a definitive correct answer. It did involve many of the eastern Oregon counties.
I assumed, I just was curious which ones.
Yep, we'll get those to you for sure. Thank you. Does anybody else have any other questions? Sorry, as we go. Oh, yes, please.
The point. Oh, sorry, Emery, you got your hand up. My bad.
That's okay. Actually, could you just flip between the prior two slides? I just wanted to confirm something about the SEAC counties. I thought I saw PEB was a lot worse. Okay, so PEB's at about low 60s. Can we go up one to the OEB? Yeah, so I don't know if there's anything you can say about like how the difference is between OEB and PEB in terms of the SEAC access. If it's like just specific locations where it's much more difficult to find a provider versus, I don't know if there's anything else you can say about that.
Yeah, I love it. I think there's a couple factors going here. The SEAC patient population, if we look at sample size, is quite a bit smaller. So when we get into some of the pediatric data, you'll actually see a huge jump in increase in SEAC utilization of preventative services, I believe in children. I'm just going off of memory. And then you'll see some where it'll drop quite a bit year to year. If you also look at, dental offices that we have in those counties, they'd be either pulling into Southwest Washington, hitting some of, Richland and our offices in that area, pulling in some of that the kind of northeast corner of Oregon, or they'd be traveling over into our Nampa, Boise, or Meridian offices just right across the border. The patient population and number of that we have in those areas is not real robust. So.
I'll make a comment, Bill. This is not correlation or causation. This is just an observational comment. If you look, and although this data is about 10 years old, but I think it's still valid. If you look at the number one cause of chronic absenteeism in schools that are due to medical, dental is by far the most, and by a lot, it's the most cause of medical chronic absenteeism. And you're looking at a large population in OEB of teachers, educators, and they're seeing this every day. So they are going to be much more acutely aware of dental work for positive health outcomes. Just a comment, not an observation, not just an observation. So.
Very true. You're correct. I mean, not only from just routine preventative reasons for missing school, but emergencies, abscesses, infection, right? And very true. And you mentioned there about the schools and kids missing school. Let's skip ahead to a couple slides. If we go to slide 15. So now if we're looking at the preventative services for children, remember back a few slides where I shared with you that preventative services for adults tend to be underutilized for high risk versus low. For children, it's actually just the opposite we find with our patient population. We see higher utilization of preventative services for high risk kids than we do low risk. And first of all, that's great. That's our goal. We want to target those interventions to those people that need it most, which are those high risk patients. And you may ask, well, why do we see higher utilization of preventive services in kids versus the adults? And I believe the reason being is that the driver of having those preventative services delivered really comes from the parents. So we found that if we can get parental buy-in and education to the parent to understand how important it is that their child follow through on preventative care, we're really successful in getting those kids to come in. On adults, we kind of fall back on some of those ingrained bad habits that some of them developed when they were real young, and sometimes changing those habits in adults can be more tricky. On the next slide, if we break down off of race and ethnicity, you know, the race and ethnicity groups were all above target, with the exception of Native Hawaiian and Pacific Islander, and American Indian and Alaska Native. And again, in part sample size, there also might be some demographic components to that as well. But it's hard to interpret because the sample sizes are quite small. If we look at PEB employees off of race and ethnicity, you see similar trends in increased utilization on the next slide, over from 24 to 25 for many of the groups. And again, part of that is that we are targeting those children and those that have high risk, and doing a lot of outreach to get patients to come in a timely manner. The next slide also looks at geography. And if we look at, we talked about earlier the disparity between rural and urban, and the disparity wasn't as large in adults. We see a larger disparity between rural and urban in children, although most of it, or a lot of it, comes from a very high overperformance or higher utilization of preventative services, higher than normal in our urban communities with children. If we look at that rural utilization of preventative services, it's still above that 74% benchmark that was set. On the next slide, it'll break down to PEB. Also, you can see that all the urban and rural communities are all above 74%. The next slide, we'll jump into the preventative measure number 7.
Can I jump? Because I don't have to ask Kaiser this, but I'll ask you, because there's an intersectionality in cluster geographics. Native Hawaiian Pacific Islanders are clustered, in certain areas of the state. Have you looked at any intersectionality of your geography versus race?
That is a very good question. I have not seen data on that, although I'm sure that is something we could pull quite easily. And Christine, we should look into that. We should make sure we take a peek at that and see. That's a very good idea.
Thank you.
Thank you. All right, so now we're going to look at preventative measure number 7. And for the sake of time, I'm going to speed up through some of this because I know we don't want to cut Delta short on their time. The benchmark was set at 48%. We've had significant improvement, a 7% improvement in OEB from 24 to 25 above benchmark, and a 2% improvement in PEB from 24 to 25. Diabetic patients are also those that are sometimes harder to get compliance with and make sure that they follow through and understand. On the next slide, I want to share with you just the importance of prevention. In order to be assigned a risk level, you have to have come into the appointment or in for an appointment and had a cleaning. And what you can see from this is that if a diabetic patient will come in, and we can provide education, we can establish a relationship with them, we can make them feel comfortable in the dental office, their future appointment consistency is quite high. If we look at OEB, if you take the average between that low, moderate, and high, it's around 74% are coming back every year for cleaning. And the key is getting them in, making them feel comfortable, and building that relationship and education. For the sake of time, I'm going to skip through the ethnicity, race, and demographic information for the diabetes, but that is all there and available for you to kind of look through. Similar trends in utilization that we see with preventative care with caries. But I do want to touch on appointment availability and performance. So going forward, a couple more slides here. One more slide, please. Wow, sorry, and one more after that. Thank you. So appointment availability has been very important. The goal was set at 60, or the target was set at 61.6%. And that is per percentage of patients that say that yes, they're definitely happy, or yes, mostly happy with scheduling availability. And we see that number at 84%, 84.1% were yes, mostly, or yes, definitely happy with their scheduling availability for OEB, and 86.6 for PEB. That's a 6.6% increase for PEB, a 3.1% increase for OEB. A lot of that has been tied to efforts being made to increase staffing and availability of patients, or appointments for patients. The next slide will show over the last 2 years, so 2024 till now. This question was asked of the patient, every patient that comes in, and they can fill out the survey to ask how likely are you to recommend Willamette Dental Group to a friend or family. And it's a 10-point scale, so they could give you a 1, they could give you a 5 or a 10, or a 7 or 8, right? Anywhere in there. And on average, OEB patients are giving a 9.2 out of 10. And PEB patients are giving a 9.21 out of 10. There's always room for improvement, but many are happy and having good experiences as they come in. On the next slide, we'll touch on the plan for 2027. A few changes are going to be happening to these quality measures. It was asked that the target be raised up to 70% for preventative services for adults, currently at 68%. Preventative services for children to be raised to 78%, currently at 74%. Oral evaluation for diabetic patients to be raised to 51%. Currently, the benchmark is set at 48%. And appointment availability raised to a target of 80%, currently at 61.6%. Some of these are stretch goals, but we're excited to take on the challenge and obviously continually improve and provide great experiences to PEB and OEB employees. Anybody have any questions that we can answer for you?
I think we threw them all out at you as we were going.
Love it. Thank you.
Thank you so much. Well, we are ready for, it's going to be Delta Dental, right? Yeah. And you have time to do your full 20 minutes. Okay. Here, over here. You can be wherever you want to be. And we're ready whenever you are. Thank you for being here.
Well, thanks for having us today. Unfortunately, Dr. Barrichello was not able to be with us today, so you get the two of us. My name is Erica Hedberg. I am the Director of Government Relations.
I'm Nathan Trenholm. I'm the Director of Informatics and Data Science.
And next slide, Rose. So today we're going to be showing the results for our current results for the performance guarantee measures. And then we're also going to break that out in different ways by geography, race, ethnicity, and age. So you can kind of see how those different groups are performing. And then at the end, we'll talk about some of the things that we do and are doing to help improve those performance on those measures. So I will pass it over to Nathan to go over all of the numbers.
Thanks. I'm a data guy, and I can just dive into the data just a little bit. But obviously, this presentation is for you guys, so feel free to chime in with questions and give me a chance to either speed up or slow down, kind of as needed. Just kind of let me know what you're looking for. And with that, just to kind of orient you guys to the measures, just as a quick reminder, we have 3 measures that we're going to talk about today: the preventive service for adults, preventive service for children, and the oral health evaluation for adults with diabetes. So the preventive service measures are kind of population-based, really kind of just trying to look at how is our population doing. And then we do some kind of deep dives that slice into those. And then the diabetic measure is looking at specifically for those members with a diagnosis of diabetes primarily identified through our medical coverage. So there's some kind of cross-pollination between the medical and the dental lives there. So let's go to the next slide. And just as a reminder for 24, there were no performance guarantees at risk, but for 25, we did have some targets that we have listed here specifically for the rural populations on those preventive measures. So really trying to help us focus on kind of closing some of those health disparities that we're seeing between the populations. And so we'll talk a little bit more about those at the end or kind of throughout the process here. But just wanted to kind of orient you guys to a little bit to what you're going to see. Let's go to the next slide. All of our metrics we compare to a peer. And so for the OAB and PEB populations, we're looking at our Delta public peer. And just as a little, I think there's a little bit of a typo on this one. So the average age distribution is, if you look at the graph on the right, that has the actual public peer. But you can see that basically PEB and OAB are both very, very similar to the peer groups. So we feel like the peer is a really good representation of kind of where we're at. And we do see as we go through this, some pretty big differentiation between the performance between both the OAB and PEB groups as well as from our public peer. And we've got a lot of lives here. So we've got a little over 100,000 lives overall enrolled, and these measures are focused on those that are continuously enrolled. So we're looking for those we have really kind of complete data on, and we can see that it's just under 100,000, which is something we kind of see. There's a little bit of kind of churn throughout the population, but this is a really good sample size for us to really kind of be able to look at as a whole. It does start to break down as both guys here and Wilana Dental mentioned, as we start to kind of drill into some of those kind of finer categories, we just don't have enough membership there to really be able to say with a lot of certainty. And so for the purposes of this report, we really rolled those categories into kind of an other category just to be able to try to provide some meaningful comparisons. So you'll see that as we go through. If we go to the next slide, please. So this is a summary of our overall performance. And just to orient you, OAB is on the left, PEB is on the right, the peer group is in the middle. And then the arrows indicate more than 1% of change, either in an up or a down direction. Fortunately, we'll see a lot more up arrows than we see down arrows, but there are a few kind of sprinkled through here. And so this is our overall performance. We can see that there's some really, for both OAB and PEB, high performance relative to the peer groups. And we see a little bit of increase on the OAB side year over year. And PEB has been a little bit flat. They do have some slight increases, but it's just less than 1% to really kind of drive that to that kind of up arrow. But again, we see pretty high performance within these groups relative to the peer. So the fact that PEB is flat is, I think they see that as really a good thing. This is kind of sustained high performance for these measures. Go to the next slide. All right, so we're going to start slicing a little bit deeper into the different breakouts for each one of these measures, and we're going to start with the preventive services. So this one is preventive services for adults. And just as a reminder, this has the performance guarantee targets in here. So we added an extra column on the rural side, so you can see kind of how we stack up against the population. And here, I think is some really great news where we're really seeing increases on the OAB side in particular across all categories, but more specifically on the rural side, it's closing the gap. So we're seeing a faster increase on the rural side than we are on the urban side. So we're seeing improvement on both categories, but rural is coming up a little bit quicker. So that's really fantastic news. That's something that we've been really kind of focused and interested in making sure that we're supporting those rural communities and allowing some of that access to preventive services. And again, sustained performance above the peer group, both for OAB and PEB, and above the performance guarantee targets. Going to the next slide. So similar story with race, and so this is where we basically rolled all of those other race categories into that other category just to try to get a little bit larger volume to really kind of say something a little bit meaningful. And this is where, because we kind of collapsed all this together, we lose a little bit of the granularity, but we do see that they're actually on the OAB side outperforming the white population in terms of closing that gap a little bit. So there's still a disparity. That's definitely something that we're working on. But the gap is closing, particularly on the OAB side. And so that was something that was kind of encouraging. I think that there's still a large chunk of data in that kind of unknown category as well. So that is another area of focus, is really just how we can better kind of identify within this population to really be able to drive more specific improvement opportunities. And on the PEB side, again, sustained performance. Again, it's very slight improvements, but we do see a little bit of improvement there from the 24 to 25 category. So I think that's another area that we'd love to see a little bit more improvement on, but it's still kind of chugging along and it's relatively.
Make the same comment I made to Willamette, but clarify it a little better than what I said 10 minutes ago. If you can do the intersectionality and not summarize it up, because there's definitely certain two categories in particular that we're paying attention to, which is the American Indian.
Okay.
But looking at the cluster of intersectionality of rural or geographic versus race, but not doing every permutation, just where you see clusters report like we noticed this cluster here and this is the result.
Yeah, we can absolutely take it back for a deep dive. Yeah. All right. If we go to the next slide, please.
Just a quick comment, and this is across all of the presentations we had today, is I think it would be helpful to have a pie chart to understand, when you have the race, just, how small or large are those numbers? Because I think there's no context for the data. And I totally appreciate that some of these groups are very small.
Yeah, absolutely. That's definitely something we can provide is a little bit more breakdown on what those categories look like.
Just as we go into that section, just so we have a kind of recalibrating. Thanks.
Yeah, absolutely. And I think that's helpful kind of across the board as we look at, ethnicities and rural urban status.
Yeah, geography as well.
Exactly. Yeah. So that's definitely something we can provide a little bit deeper breakdown. As I mentioned, it's a little bit harder to kind of dive into when we're trying to just like show all of the categories, but yeah, we can definitely provide that as a follow-up. All right. So similar story here. Actually, this is one where we're seeing the Hispanic growth a little bit higher than the non-Hispanic for both OAB and PEB. So that was, again, really encouraging to see as we're starting to close those disparities a little bit. The non-Hispanic is still outperforming the Hispanic, so there's still a little bit of disparity. And that is something that we see kind of across all of our populations. And it's, I think, part of the performance that we're seeing. Again, that gap is just closing a little bit. And if we go to the next slide. So this is the breakdown by age. And so this we see a pretty general curve. So the younger folks tend to be the invincibles, and they don't go into to see care very much. And then you see quite a bit more utilization, and then it starts to taper off a little bit as we get to those older age bands. And the thing that I was most encouraged about on this slide was really that 25 to 34 age category. So we saw some increases on both the OAB and PEB side. And this is really an indication that those folks are starting to seek care at a younger age, and that is something that we would expect to see kind of carry over. So they're starting to set some good habits as they move into their kind of professional lives and get a little bit more stable. Is that hopefully that will help carry over as they move up to those age bands, and we'll see some kind of sustained increases overall.
That's a question for Ali, that's not a question for answer, just throwing it out there. Is it the demographics between OAB and PEB showing up here, or are we doing a better job communicating to OAB members about dental things? I'm just saying, just asking that question in general, right?
Yeah, I mean, I don't know what other staff if you have input, but I mean, I think educational entities kind of have a secondary communication that maybe we miss a little bit with the state.
It's just a
yeah.
Right.
Yeah.
There's a big difference in demographics on the membership pools as well, right? Just a thought that popped in my head.
Yeah. Yeah, the demographics are different, but OAB is much higher female and younger active population than PEB, and just in general, it's a healthier population.
Yeah. I'm happy with all our green areas.
Yeah. It's really nice to see a good improvement across the board on the OAB side.
Yeah, and I agree with Ollie's comment. I think it does make a difference because on OAB you do have those entities that act like an employer. On PEB that is often missed.
Yeah. We go on to the next slide. Right. So now we're going to start talking about preventive services for children. So again, this is the breakdown by geography, where we have that extra column with the performance guarantee targets. So that's looking at those rural populations, and for both OAB and PEB, we are above the set target rate, which is fantastic. And we also saw year-over-year improvement in both categories. Very similar performance here between OAB and PEB. So I think that's an area where the kids, people understand pretty generally that it's important for kids to get in. Again, kind of closing the disparities. This is kind of a consistent message we're seeing kind of across this data for the 24 to 25 category or years. We're seeing the rural outperforming or closing the gap rather on the urban side. There is a little bit of the out-of-state dip on the OAB side. I think that's something that, again, that's not a very large population, and so we get some swings there. So I think that as we come back with some more data, just run the sample sizes on those, that'll kind of show what's going on there. But again, that's still pretty high performance, especially if that tends to be those kids that are going to college, and those are kind of those invincibles that don't seek services nearly as much. The next slide. Right. So looking at the breakdown by race. So again, very similar story to what we saw on the adults, where we're seeing improvement kind of across the board on the OAB side, and closing the gap between the kind of other categories and the white. So kind of relative to the performance, they are improving a little bit quicker. The PEB side, again, fairly stable, but here we did see actually a little bit of improvement on the white side. I think this is really, we see across the board with PEB slight improvements, and this one just, I think, happened to take over that 1% threshold to get the green arrow. But I think it's a pretty similar performance that we're seeing on the PEB side, is that they're generally just kind of chugging along fairly stable in their population and their performance. Go to the next slide, please. Similar story here for ethnicity. Again, kind of closing the disparities with both the Hispanic populations for OAB and PEB, improving a little bit more quickly than the non-Hispanic populations. The unknown category is relatively small here, so it is going to see a little bit more variability. But overall performance, again, is quite high. Although this is an area where we do see the non-Hispanic peer is ticking up. And so it is kind of closing that gap just a little bit. And it's, so we can see it's actually at the same level as the PEB side. But I think, again, the performance here is really strong. People are feeling like kids are getting in, they're getting the services they need. And so that's really encouraging. So again, this is the age breakdown for kids. So this is a little bit different of a distribution, just because there's some of the kind of factors associated with the children's development. So the less than 2 folks just have very, very low utilization. They don't usually have a lot of teeth, and they're really just looking for kind of that first visit during that time, just to kind of get the kids kind of oriented to the dentist. 3 to 5 and 6 to 9 are really where there's a lot of development happening. They're starting to get the baby teeth come in, the baby teeth start coming out. And so we do see a lot of engagement there. And then it does start to taper a little bit as they get to the older age kids. So pretty standard in what we see kind of in the age distributions between the peer groups and OAB and PEB performance. We did see a little bit stronger improvements for the OAB performance between the 24 and 25 category. And I think we've kind of covered a little bit about some of the differences between the population that could be driving that. Let's go to the next slide. So this is looking at the oral health evaluation for diabetics. So this is that kind of intersection between the medical and the dental services. Overall here, the message is that basically we're seeing pretty strong performance, but it's relatively flat across OAB, PEB, and the overall peer group. So there's not a lot of movement here for this year. The out-of-state did have a pretty strong increase, but again, that population is really, really small. So I would definitely take that with a grain of salt. But this is really where we're seeing that those folks that are identified with diabetes are getting a lot of wraparound support services, both from the medical side and the dental side. And they are coming in for care pretty regularly. So we do see that this is a relatively stable population and don't see a lot of change here kind of year over year. Let's go on to the next slide. And I think we've kind of covered a lot of the conversation around this between the different age and gender, sorry, not gender, age and rurality race breakdowns. So we'll just kind of skim through these, but if there's any questions, definitely feel free to chime up with them. We can go into the next one. So similar here with the Hispanic is something we do see closing the gap, kind of, as I mentioned, kind of across the board. The unknown category, again, is relatively small, so we do see a little just more variability there, which I think is driving both the large swing on the PEB side as well as the kind of decrease on the OEB side. With a small population, it tends just to be a little bit more unstable. Next slide. Pretty similar age distribution in terms of folks that are coming in. And this one, we do see it actually is a little bit flatter than the preventive services, which I think is really more of an indication that when members are identified with diabetes, like I said, they're getting a lot of messaging around, what is the appropriate level of care. And that's a little bit less dependent on people's age. So those that are identified with diabetics as earlier tend to be a little bit higher acuity, and they're coming in for services. So we do see a little bit of more kind of a flattening of this overall curve. Next slide. And then the last one I want to talk about is our CAPS measure. So this is the survey looking for access to care. So this is specifically the access to care. The survey actually assesses a pretty broad level of satisfaction with with members' ability to access care, the quality of the providers, and the quality of services that they receive. Here we are looking at the access to care measure specifically versus the DDPA national benchmark. And we can see that with both OEB and PEB have significantly higher performance than the national benchmark. So this is something where we monitor every year, and is really encouraging to see that results are fairly consistent. So we see the kind of mid to high 80% range, and that we're usually 3 to 4% above the national benchmark. And so this is something that we are particularly proud of with just a broad network, really making sure that access is addressed and focused on that. If people need to get in, they're able to get in a timely fashion. I think that closes out the data side of the slide, so I'll pass it over to Erica.
Great, thanks, Nathan. Next slide, Rose. So I'll talk about some of the strategies that we use to try and increase utilization rates and improve those measures. One of them is with our benefit design. There are lots of things included in the PEB and OEB benefit designs that help incentivize and encourage members to go in for preventive utilization specifically. And those things include things such as low or no cost preventive services, and also with our incentive benefit design, where if members go in on some of our plans, if members go in and have a service done every year, then their benefit improves by 10% until it's up to 100% coverage. So those types of designs are really trying to get members to come in and remove barriers to being able to access the preventive care. In addition, we also have the Preventive First program, and both PEB and OEB have this benefit. This is not a standard benefit of ours, but it is absolutely one of my favorites. And it makes it so that the costs for preventive services do not accrue towards that benefit, that annual benefit maximum. So if members need to have work done, like they're having, more expensive, like an implant, or they have lots of fillings that they need done, and they use that whole annual maximum, they can still go in and have their preventive services done because it's not going to be affected by that maximum. And then another benefit that we implemented here not too long ago is the intellectual and developmental disability benefit. And that is really designed to help members who have some developmental delays feel comfortable with coming into the provider's office. So they get assigned a case manager who can help navigate them through accessing the dentist. And then we also cover additional services for them, such as a pre-visit, so they can go in and kind of learn what to expect from going into the dentist. And then it also covers sedation for them as well when they have services, just to kind of ease some of the nervousness they might experience from going to the dentist. In addition, we also have our oral wellness programs, such as Health Through Oral Wellness. This is a program where members, when they go into the provider's office, they'll do a quick assessment on the member to help identify their risk for developing cavities and gum disease and cancer. And so based off of that score, right as they're sitting there in that chair, if they score at risk, it'll move them into an enhanced benefit right there, where they'll get access to additional preventive services, including cleanings and fluoride and services such as that. In addition, there's a lot of things that we do outside of just the benefit design. We do assist members during open enrollment benefit fairs. And especially on the OWEB side, there are a lot of benefit fairs that happen during open enrollment. We know because my team personally goes to each and every one of them throughout the state. And we have a great time doing it. But it really gives us the ability to be able to work with members and talk with them and answer their questions about their dental benefits and help them find in-network providers. And then the Moto 360 Health Navigators. So these health navigators can help members find providers who are accepting patients. So if a member is having trouble finding a provider or finding one that is accepting new patients, the health navigators will do that work for them. They'll call around, find providers who are accepting patients that meet the needs of the member, and then bring the member into that and help them get that appointment scheduled. So that can really take some of the anxiety off of the member as well. Next slide. Network management, this is also important because we need to ensure that members have providers that they can go in and see. And so we take our recruitment and retention of our providers very seriously. Some things that we do to work with our providers as well is that we have provider workshops, virtual trainings where we educate them specifically on the PEB and OA benefits. We do focus our workshops on more rural areas because we really want to ensure that those providers there understand the benefits. And one of the things that's key for those providers in understanding them is if they know the benefits such as the health or oral wellness program or the preventive first benefit, it'll help them be able to talk with members when they're there at the office about what their benefits are. So if they know that they have preventive first, they can say to the member, just so you know, I know you've met your benefit maximum, you can still come in for your preventive care. In addition, it'll also encourage them to reach out to the members. That's one thing that dental offices are very good at, and I'm channeling Dr. Barakello on this because she's the one who always speaks to this. But providers are very incentivized to get members into the office. So they really do a good job of reaching out to members when they haven't come in to the office. I know my dentist is harassing me right now because I missed my last cleaning. So I'm getting calls about it right now, which is exactly what we're hoping that our providers are doing. And next slide. And then in addition with Moto 360, we have care reminders. So when members go into their member dashboard, if they have medical coverage with us, they see medical reminders. And if they have dental coverage with us, they'll see the dental reminders as well. So members are getting both of those. So if they haven't had their cleaning or if their cleaning is becoming due, they will get a care reminder telling them telling them that it is due. In addition, if they've downloaded our app, which I hope all members do, it will send them a monthly reminder about that care reminder as well. So they'll be getting, a reminder being sent to their friend, reminding them that they need to go in and have their preventive visit. So we try and find lots of different ways to hit members to help remind them about preventive visit and encourage them to go in for those visits. And next slide. Thank you. Any questions for us? Great. Well, thank you so much for having us.
Thanks a lot. Yeah, so we can take.
So let's take a 10-minute break till the 10:30. We'll do the summer.
Restrooms are just through the hall to your left. Yeah.
Oh, sure. Thank you. And thank you, Kirsten. Yeah.
for some summer work. Is. Right. I got the Keurig running, but we can get started.
Yeah, no worries.
So go for it.
Yeah, thanks.
Okay,
Bill.
thanks. Thanks, Bill.
Uh-oh. Is that normal?
Sarah.
Can you hear me okay?
I hear you.
Okay, great. And do you see the screen? I think I can see it on my end.
The presentation is slightly too early.
Sarah, you're not up yet. You're next.
My apologize. Okay.
It's okay. If you want to do the summer research group, you know.
So remarkably sounds like my
Yeah, let's do it. That sounds just like you. If you had shipped us free samples for the meeting, I would have let you go first, but.
Fair enough. Fair enough. I'll defer to Kirsten.
It's May, so it's that time of year where we're recruiting into the summer research group. So remarkably, this is actually going to be our 4th summer of the summer research group. We started off as an experiment together, and it turned out we get to accomplish a lot with it. So this slide just gives a little bit of history on the SEOW Summer Research Group. We kind of call it the SSRG just because otherwise it's a mouthful. The structure is a really collaborative effort between OEB, the carrier partners, and OHA staff, and then of course Mercer. And we all come together a couple of times over the summer to do a deep dive on a topic of our collective choosing. The goal is to support SEOW by spending a little extra time on a topic that's more nuanced than we can handle during the normal monthly cadence process. We've had some really exciting outcomes at the start of these meetings. You know, sometimes we don't know what we're going to find, and that was the case last summer with the HbA1c reporting project. One of the things we talked about is that OHA's mission is to really be innovative and transformative with healthcare in Oregon, and sometimes that means we set out to be a little experimental at the front end, not knowing what we're going to find out. And so we worked last summer on the HbA1c reporting data with our carrier partners and all the other groups, and got some really exciting data, and that's what Sarah's going to speak to next, and Nikki also, a pharmacist too from Mercer. We also added doula coverage. That was one of our original implementations from the SEOW Summer Research Group. Also that summer, we did a deep dive. That was the first time that we collectively talked about the role of weight management drugs and understanding all of the new therapies to market. And then in 2024, we focused on a category of providers in Oregon called traditional healthcare workers. I think maybe there are 11 or 12. There's quite a few under that umbrella. They're very successful in supplementing the main carrier PPO networks within community providers. So we didn't wind up taking any action as a result of that effort because it was more about bringing awareness and understanding how they're currently integrated and being used and endorsed their role in our access. And then at the summer of 2025, and then it carried on with some follow-up too throughout this last year. There was a focus on HbA1c data, and the goal was to understand the different treatment types for type 2 diabetes, because there's a range of treatments with a range of costs. And so this was really first of its kind with our carrier partners to understand the outcomes that we were seeing. We can go to the next slide, please. The SEOW Summer Research Group, it supports SEOW, which of course supports the board. And we have PEB and OEB coming together within the SEOW Summer Research Group. And so we're just highlighting how aligned the goals are between OEB and PEB as we try to help the boards meet these goals. So quality of care and equity are priorities, affordability, which includes reduced out-of-pocket costs, and then member education and the member experience as well. Next slide, please. So over the last year, we have at different points throughout our discussions together identified 2 candidate topics for this summer. One of those is cardiovascular care optimization. So the history on this topic, it goes all the way back to when we met together as a group for our strategy kickoff.
And we looked together at some cost and utilization data for OWEB. We don't look at PEB data in our OWEB board meetings, but Mercer works together with the Mercer PEB team also on the alignment behind the scenes. So we collectively identified that cardiovascular conditions as a whole were increasing in prevalence in our two populations and also had not been addressed yet by SEOW. And so those were a good candidate. Dr. Ian Chuang and the clinical team led some deep dive into that work and found that it's not a benefit change that we would make to promote this care. We actually have a lot in place, but it's making sure that what we have is optimized and we have reporting on it and we can see where it's working so we can identify if there are any gaps. And so we collectively decided, hey, that sounds a lot like what we just did with HbA1c, which was really successful. Maybe this work stream is best in the summer research group. And then the second topic is kind of a legacy topic, although, listening to the dental presentations this morning too, just kind of reiterates why this is front and center, thinking about dental care and access across the state. There would be four prongs to the dental care and access topic. The first one is understanding access to dental care. This has been on our list since going back years ago when I think it was even the Grants Pass office closure of Willamette Dental Group, and there were a couple of things that made us want to deep dive into dental access. Standards of dental care across carriers for cleanings and preventive services, equity in dental care, and then more recently, you might remember from last meeting or 2 meetings ago with the board, we decided we need to focus on the renewal. Let's work on the dental performance guarantee targets more deeply over the summer. When we can all come back and talk about alignment across the carriers, what would that look like? How do we set targets when there's no HEDIS benchmark? So in a way, the dental performance guarantees are a bit more challenging. So that would be the proposed first topic. So Rose, if you go to the next slide, one of our first questions for this group is, are there questions about the proposed research group topics, and are there any additional items that should be explored in each of those groups? And I know you are all very excited to join. And so the last step on this slide is you can, obviously jump on board now too, or think about it and let Ollie and staff know about your interest. We do want to have both OWEB and PEB representation for sure. Bill, were you gonna ask something?
I was, and also point out that I volunteer for everything, so.
Thanks.
I was thinking on the cardiovascular, one thing that I always, this is kind of one of my constant drum beats, right? To look at the difference between gender care and results. Seeing if there is a bias in gender for cardiovascular care would be my big interest.
Sure.
It's hard for me to imagine a gender biased dental care, but there might be. Maybe I should ask an expert. I can visually mental the bias in cardiovascular care based on other things I've seen in reports, but dental care, I just never really can imagine a bias on that.
Are you asking for an OEP board members as a whole or within the SEOW group?
It's open to everybody.
Yeah, it's open to everybody. We're starting with SEOW, but we can, if we don't get enough SEOW members, what we can do is send emails out or to the board members or.
But I'm always happy to defer to any member that really wants to do it. It's fine.
I believe Kimberly Hendricks was excited about the cardiovascular topic. Does that ring a bell to people too?
This is Robert. I think I've been on this summer research group past 2 years, I think. I don't mind doing it again. It's these topics are something that are not anything where I can contribute, but I really do like listening to the experts as they go through the process.
Robert.
Does that include?
That's it for me.
Sarah, now let's hear from Sarah, all the way from Minnesota.
All the way from Minnesota, and it looks like a beautiful day in Portland. I'm looking out your windows. Looks gorgeous.
Not cloudy, but
yeah, it was a balmy 36 this morning, so I'm a little jealous, but that's okay. So we're here today. If we want to go to the next slide. There we go. So I'm here today. Kirsten already mentioned Nikki, and I know some of you were able to meet with her before the meeting. She's another pharmacist on our Mercer RX team, and she hails from Portland. So it's great that she's here and she's available to support OWEB, MPEB, and the SEOW, and she has done some of the work on this particular project. So I was glad she could come in person today. So what we wanted to do today is give a little bit of background on the previous summer research group effort around looking at hemoglobin A1C and some of the different treatment paradigms we're seeing across the carriers. We have some updated findings to share following some back and forth with the carriers, and then talk a little bit about next steps. Before we get into it, I did want to just give a call out to all the carriers have been very collaborative through this process, sharing their information, and it really helped us to deliver a better product. So thanks to the carriers that are here, both in person and virtually today. Next slide, please. Yeah, so as just some background, as a reminder, last year's summer research group really wanted to focus on incorporating some outcomes data, seeing what's happening in the populations around type 2 diabetes treatment. Specifically, we wanted to look at if there were any associations or any patterns we saw between different types of drug treatment and what we were seeing with hemoglobin A1C, which is a measure of blood glucose improvement or blood glucose management. We presented in the December SEOW meeting, and we determined that the data that we had, as was provided from the carriers at the time, really didn't allow us to dig into differences in treatment complexity and how the medications were being prescribed for people in different treatment complexity groups. And also we wanted to better understand if there was any effect of different regimens of medications for people who were more or less complicated. So what we've done over the past several months is we went back to the carriers with a defined template and asked them to all provide their data in the same way. That allowed us to combine and compare the data in a way that we weren't able to previously. So we wanted to show that today. Also wanted to just note that in this reporting, we're focusing on the non-insulin-based treatment regimens, and especially those that included GLP-1 or SGLT2 and metformin. Those are the most commonly used medications, and as we know, the GLP-1s and the SGLT2s are some of the newer branded medications, and they're being used more and more in some of the treatment guidelines coming out of the Diabetes Association. Let's go to the next slide. So goals today, we're going to review the revised findings and then identify the next steps. So before we get started showing the data, one of the things we did just to not glaze over everybody in this meeting, because there was a lot of data, there's a lot of slides, we combined OWEB and PEB. And so all of the data that you're going to see is combined OWEB and PEB. Let's go to the next slide. So some general observations before we start going into some of these graphs, and Nikki will be walking you through some of those. The first bullet, we'd seen this before in the December presentation. We did see a big difference in utilization patterns across the carriers. We saw there was much higher utilization proportionally of the GLP-1 regimens in MODA and Providence than what we saw in the Kaiser population. By far, the largest treatment group in Kaiser was metformin and metformin alone. In this new data, we were able to look more at the different treatment complexity of the different members. And what we did see is, unfortunately, there was uncontrolled diabetes, and we're measuring that as high hemoglobin A1C. And that was present across carrier populations, and it was present also across categories of complexity. Most members across all carriers were controlled. That's the good news, but there are still uncontrolled populations, even in those low complexity patients. Another interesting thing we saw is, high utilization of GLP-1s. We knew that from the December reporting. Kind of what's new here that we're seeing for the first time is we're seeing high utilization of GLP-1s, even in members that have fewer comorbidities, so those less complex patients. And there is some difference here across carriers that you'll see. And then finally, what we saw, which was a good thing, I think, we saw proportionally more utilizers of GLP-1s made improvements period over period than the utilizers of metformin alone. And I think what was really interesting here is that the effect seemed to be more notable in the most complex patients. So that's good news. We're seeing like this is a new tool in the toolbox. It does seem to produce better glucose control, especially among people that are the most complicated patients. Okay, let's go to the next slide.
A quick question on that general observation, and I know this is post your last summer work group, but is there a trend increasing GLP-1s for diabetes with the approval of the pill version?
Not yet. I mean, I'll take that two ways. Number one, there is increasing utilization of GLP-1 generally. I think most of that is driven by changes in the treatment guidelines from the ADA and some of the other clinical groups. The oral product for diabetes really has a very low market share compared to the injectables. We really haven't seen a big jump in utilization with the oral product for diabetes. It's called Rybelsus. It's been on the market for several years now. It has very low market share. The market leaders are Ozempic and Mounjaro, which are the weekly ones, the once a week injectables.
I wouldn't have predicted that, but.
So this slide is some data just to kind of refresh what you've seen before. And in the December meeting, we provided some additional breakouts looking at race, ethnicity, some of that information that we had available there, really wanting to understand if there were disparities in reporting. So what's included here in each of these charts, it's those members who met criteria for inclusion in this study. And so that meant that the individuals had to have a hemoglobin A1C in each of the 1 year periods. And those two hemoglobin A1Cs needed to be at least 6 months apart. So that's who's included here in these reports. People who didn't have adequate observations of hemoglobin A1C were not included because we didn't have data. So recognizing this is imperfect, but this is what we had. So if you look in Kaiser in the upper left quadrant, the purple, that's treatment group I, which is metformin only. And you can see that represents almost 60% of the total number of people who were included here in this study. In contrast, in MODA and Providence, that the purple is 21 or 22%, depending on the plan. Also want you to look at groups D, E, and F. So that's the light green, like the almost black, and then the royal blue. So when you look in the Kaiser population, the D, E, and F, that's a very small portion of overall individuals here in the study, compared to in Providence and MODA, which you're looking at 40-ish% in both cases. And those are the GLP-1 utilizers. So similar to what we saw previously, that there is proportionally more utilization of GLP-1 in MODA and Providence than what we were seeing in Kaiser. Let's go to the next slide. Okay, and this shows the Charleston Comorbidity Index. And so this is a measure of the complexity of the patients. And so a couple of things to note here. So that the very dark, almost black blue is low comorbidity index. The royal blue is moderate, and then the light blue is high. So what you'll see here, higher CCI means more complex patients, more comorbidities. And so what you're seeing that I found kind of interesting is proportionally we did see, looking at these populations, there were more higher complexity patients proportionally in the Kaiser population compared to what we saw in MODA and Providence. MODA and Providence, we saw proportionally more low and moderate complexity patients. And in some of the subsequent slides, you'll see how the treatment groups are distributed by the complexity, as well as what we were seeing in hemoglobin A1C over time. So any general questions here on what's included in the data, how we're defining the comorbidity index before I turn it over to Nikki to go over some of the detailed charts?
Did you limit the measurements to blood draw, or because like I know where I go, Providence, they do use an in-office kind of home kit sometimes, and then sometimes they use a lab blood draw.
So it's based on the data that's reported by the carriers. And so I think it's up to the carriers in terms of what they cover in terms of types of blood draws, but it's the value of hemoglobin A1C reported by the carriers. Okay, let's keep going. Next slide.
Okay, so on the next slides, we have the distribution of patient complexity by both A1C value as well as the CCI risk. The slides will start out by first reviewing each of the carriers and then reporting data across all of the carriers. Now in this first slide, we have Kaiser. On the left, we have the period 1 A1C results, and on the right, we have the period 2 A1C results. Each of the bars represents the overall risk associated with the CCI index, and then within the bar, you'll see the overall brackets of the A1C control. Key thing to note here, as Sarah already mentioned, is that within the Kaiser group, you will see the largest proportion of members that are concentrated there within that high risk CCI index there. And the slide really calls that out.
Nikki, can I ask Dr. Mueller a question?
Yeah.
This is what I'm wondering. How, so we have all of Kaiser members.
Yep.
And then we have Kaiser members with an HbA1c level that met criteria for inclusion in this report.
Yeah, and I think that was about 84% or something. We got into the study.
So then of those members now, we've distributed them across the comorbidity index.
Mm-hmm.
What I'm wondering about is how do you initially decide who to give an HbA1c test to or not?
Well, so if a person already has an established diagnosis of diabetes, we might be measuring it regularly, right? Especially if we're changing treatments, we might be checking every 3 months. If you're very stable, we might be checking every 6 months or 9 months. And then for people who are pre-diabetic, our integrated health record will say, hey, doctor, patient is showing up hypertensive or their lipids are high. They're in a certain age bracket, you might want to think about an A1C. So we're really trying to find those people who are kind of pre-diabetic, catching them upstream before they get into these, and especially into a high risk category.
Yeah, I was wondering if maybe the integrated model with your EMR was maybe helping you
100%.
catch people.
When I go into a visit, I'm already thinking about that clinically, but when I go into a visit, the EHR is also helping me saying, you're probably going to have a higher catch ratio if you do an A1C on this patient.
I'm sorry, I have a question. I'm not clear what the numbers inside the bar represent. Is that number of people?
Yes.
Yes.
Yes. Counts number.
Which is what my question. So if I have a high risk person and I'm getting positive treatment, that's going to bump me to the moderate. So the high risk in 1 may be medium risk, moderate risk in 2, right?
No. So the way this data is, it has to do with the comorbidities, and people are classified that way only one time for the purpose of this data. So people are not moving from low CCI away from low CCI. Everybody is categorized only once.
But we would see them move from HbA1c bracket from one to the next, right? Just to, so that's where we're seeing the shift.
Yep, that's exactly right. And that's Nathan on the phone. He's another pharmacist on our team who helped out with this data. Thank you. So yeah, where you're going to see it shift is, so for example, in that low CCI category, you've got 89 people that are in the less than 7%, which is what we would consider a controlled hemoglobin A1C. Between period 1 and period 2, so over the course of that year, an additional 9 people achieved control because 98 people were in control there.
Category, right? Those additional 9 people that are now less than 7% were in the original group greater than 7%.
That's right. That's right.
Yeah.
Yep.
They're bouncing down the bar.
Correct.
Right?
Yeah, they're just moving
down within
Correct.
the bar.
Correct.
Within
yeah.
the bar. Yep.
Yeah. And when you do look across each of the individual risk groups, when you do a comparison of that overall, that dark blue black bar, you will see that the counts do increase across each of the risk categories there.
We don't know how many people actually got below 7 because people are coming down into the 7 category, right?
You can have shift within the bar.
So,
Yeah.
Okay.
Yeah.
So if they were initially diagnosed in low, they stay in low and shift up and down, or if they were initially diagnosed in high, they stay in that and move up.
Yeah,
that's right.
You got it.
Finally.
You got it. Robert has a question too online. I saw his hand come up.
See you, Robert.
So can somebody explain the significance of period 1 versus period 2? For example, are these the same people? Are they different people? Was there some type of, are we tracking some type of change in let's say, pharmaceutical distribution, or how am I supposed to read that?
Yeah, so it's so period 1 was a 1-year period. Period 2 was the second 1-year period, and I believe it was July to June 2024, and then July 23 to June 2024, and then July 2024 to June 2025 was period 2. The individuals that were included in the study were the same individuals in both period 1 and period 2. If they didn't meet the criteria, meaning they didn't have a hemoglobin A1C in one of those periods, they aren't going to be shown here. So it is the same number of people, and it's the same people in period 1 and period 2.
Then, right. Okay, gotcha. Great.
And then I think, are we okay to go ahead and move on to Moda? Who's next? Okay, so next up on the screen, we have Moda again, and very different results as you see from Kaiser and overall distribution of membership. As you can see, the majority of the members are concentrated within that low risk group, which is very different from Kaiser, where we saw them concentrated within that high risk group. Again, if you focus on that overall less than 7 and do a compare between period 1 and period 2, you do see overall increase in the numbers as well, which does tell you that there was overall improvement within the members there. And then Providence is up next. Very similar results to Moda. Again, that you'll see the majority of the membership is again concentrated within that low risk category. Again, similar movement there as you do see improvement in the overall member counts to that less than 7%, which does reflect the in control.
Just for my education, is the Charlson Comorbidity Index, is it pretty rigid or is it flexible and has bias?
My understanding, Sarah, it's pretty rigid, correct? It's standardized.
That is my understanding. And I don't know if there was anybody else Dr. Ian wasn't able to join us today. I didn't know if there was anybody else who had more expertise in the CCI that wanted to weigh in.
That's enough information for me.
Okay. It is my understanding, it's a definition and it's a standard definition.
Okay. And then on the next slide, we have the results, which include all of the carriers. Again, similar reporting. Again, if you look at the bars there, broken down by each of the individual risk categories as well as the A1C. So I'd say there's probably three key takeaways, or at least that jump out to me, would be that I would say the greatest proportion of patients in glucose control is actually within the lowest CCI risk there. So if you look in that overall categories and the percentages there of those first two columns, you'll see that those percentages are the highest within your low risk categories. The greatest change in A1C control was actually seen within the moderate group, which is reflected within that third column there. And I would say probably the third take-home point would be that the still greatest opportunities with the high-risk group. Any questions?
Low-risk people don't take it so seriously.
So maybe this is the next part of your presentation, but what would cause a person to move up or down in the risk category within that bar?
So they would stay within the same risk category, but overall, I think what we're seeing within the bar itself, you're seeing shifts in A1C control. So it could be overall effectiveness of therapy that they're taking.
For this study.
Yes, for this study.
I mean, if I had a major heart attack and I was low, that's probably going to put me in high just for or just general data, right?
You'd have to have your diagnoses fall off your claims record over time to be classified in the future as a lower risk on that comorbidity scale.
But for this study, you kept everybody in the same.
That's just the same cohort.
Just for this study.
Yeah.
I guess I'm asking a deeper question of what, I mean, you're talking more about symptoms, but what causes the symptoms to go away? What causes those diagnoses to fall off the chart over time? Is it weight loss? Is it exercise? Is it?
Well, for this study, the study is focusing on which medications.
It's just medication alone.
Control. So this one is just medication, and it's just looking at for members between period 1, period 2. Ignore the comorbidity index thing for a second.
If the patient did nothing other than take the medicine.
Yeah, exactly. Nothing except the medicine. Ignore the comorbidity index. What happened in the 6 months?
All other factors are
Measure 1 and measure 2. Yeah.
Yeah, but I think it's a valid point, right? We only have the data that we have, and so we have the data of what medications regimens the people were taking, but we don't know what else they're doing in their life. So certainly somebody could move from, a 7 to 8 hemoglobin A1C if they're using medication or not. And well, in this case, they are using medication because they're included here. They could be using medication, but also changing their diet, also increasing their exercise. There could be more going on here that we just don't have insight into in our data. But what we're just trying to look at is what's happening over the period of time. And you'll see some more data dividing out the different drug treatment groups. What's changing as far as how many people are in control of their diabetes versus people that have those high A1Cs that are considered out of control for diabetes.
I see it. The moderate people are taking it more seriously. That's all I'm gleaning out of this.
You do see the greater percentage in control within the moderate group.
Although, Bill, I would say that the moderate group, there's fewer of them, even in period 2, even if they are taking it more seriously, there's fewer of them that are in control than with that low group. So at some level, there's less opportunity to improve for the low group because the lower group had a higher portion in control to start with.
Yeah, understood.
Next up, we have the improvement in blood glucose control by treatment group on the next slide. Okay. And again, this will follow a similar pattern, looking at each of the individual carriers and then across all carriers. So first up on the slide, we have the results for Kaiser here. And just to get everyone familiar with the screen here. So the overall therapy groups of D, E, and F associate with a GLP-1 or some form of a combination of a GLP-1, either with or without metformin or with an SGLT2. The G and H groups there, those are associated with your SGLT2 therapy or some form of a combination there. And that group on the end, your I, that's metformin and metformin alone. Yes. So we talked about within the overall Kaiser utilization patterns that was highly concentrated within overall metformin. And the slide really highlights that, as you can see within the overall therapy there. I'd say probably key takeaway though is that even though there is high concentration or a high utilization of metformin, you can see some improvement there in glucose control. When you look at that overall lower number there within the bar, it went from 232 to 257 members that are within the overall control.
And the concept that metformin is almost essentially free.
May I make a quick comment?
It's an easy one to jump on, right?
Yeah.
Can I make a quick comment?
Yeah.
Just to put this in some perspective too, the study we said ended in kind of summer of like 2025. That's really about the time that our GLP-1s came down to second line. So we knew that was going to be represented here. And I know we're not talking a lot about insulin, which is group C, but that's another. So it's not just metformin and nothing else.
Yeah.
We do use a lot of insulin in our system before being able to make the big switch to high utilization of GLP-1s now going forward. And because we're integrated, when that formulary change happens, it just kind of goes quickly. So we are moving people very quickly now.
Okay, and next up we have the results of MODA. Again, and to your point, it really just highlights the overall differences in the coverage criteria. So as you'll see within the MODA group here, in looking at the groups of D, E, and F, you do see much more significant utilization of that GLP-1 therapy there. There still is that overall metformin in the group I, but again, much more significant utilization of the GLP-1s there. And then if you go to the next slide for Providence, again, very similar results with the MODA again, in that you do see that overall more significant GLP-1 utilization there. Probably one thing to call out though that jumped out at me at least is if you focus on that group I and look at that first number within the bar, there actually was a decrease in the amount of members that were in control with the metformin group. So you'll see it went down from 350 to 339 there, which was something to jump out there. Okay, and our last slide here reflects the overall data for all of the individual carriers here. So I'd say a couple key things to jump out. Overall, when you did look at the change in proportion of members achieving glucose control, that metformin on the bottom actually resulted in overall nominal results. Our GLP-1s are where we did see probably the greatest shift there. And one thing to note with the SGLT2 without metformin, we actually did see a decrease there.
And I would say that group H was very low numbers. So we saw a decrease, but it's also, there could be a lot of variability just given there's a small number in that group.
Okay, so a lot of data here, but on the next slide, we have changes in blood glucose control by patient complexity. So it's just looking at the data through multiple different lenses here. So this first slide here looks at shifts in A1C for members that were greater than 9%, and specifically whether their A1C improved or maintained, and actually broke it down by each of the individual therapies. So just as a reminder, that first group there is your GLP-1, followed by SGLT2, and I reflects your overall metformin there. So when you take a look at first your group, your GLP-1 therapy, one thing to note is that across all carriers, there was improvement within the overall GLP-1. And you can really see that with that light blue bar there, that the majority of patients there actually did improve. A couple other key things to note would be that overall with the Providence group, the SGLT2s, they actually saw more improvement compared to the other carriers. And MODA actually saw it within metformin there, which is that bright blue royal bar there.
Did your definition of improved include tolerance in the measurements? Like, do you have to be greater than 0.5, or was just any number less than what you were is good?
Hey, Sarah, can you speak to what the definition was improvement?
Yeah, so there were groupings of hemoglobin A1C level. So there was greater than 9, 8 to 9, 7 to 8, and then less than 7. So an improvement is moving out of the greater than 9. So to your point, we don't, this doesn't show any kind of order of magnitude. You know, did it go from 9 to a 8.9 potentially? Is it going from 9 to 8.1 also potentially? We don't have that.
Right.
What was that, Bill?
You shifted a group. You moved from one group to another group.
You move from one group to another group, and this is only for the people that started at greater than 9. So, you know, maintaining period over period at greater than 9 is not a good outcome.
Right. That's the perfect. I understand. Got it.
Yeah.
Right. Robert.
Thanks. So if I go to the light blue, the all, and I'm comparing DEF, GH, and I, the 70%, 63%, and 59% improvement. So how do I measure efficacy on this? Because, well, or cost benefit analysis, because just the metformin alone gets you almost to 60, and the GLPs improve 70%. So is the extra cost, I don't know how to phrase this in a diplomatic way, I guess. How much more effective by cost is, are the GLP-1s?
Way more complicated than that, though, because you're dealing with diabetes and you're only looking at HbA1c here. So
it's a challenging question. As we go further, we're going to show some slides that are kind of interesting, where we basically have this and broke it down by that complexity level, which I think tells kind of an interesting story. But yeah, you're asking a big philosophical question. And I think we can acknowledge that question and also say we don't really have enough data here to be able to answer it.
Okay, and the last thing to note in looking at that maintained on the right-hand side, when you look at that metformin group across all carriers, you are seeing the largest percent maintained with the metformin. Okay, on the next slide, we look specifically at A1C changes for those that are greater than 8 but less than 9%. Again, across all 3 carriers, the majority of the members did improve on GLP-1 therapy there, which you can see again highlighted within that group D, E, and F. And I would say specifically looking at Kaiser, I would say a majority of the members did maintain on that SGLT2, which you can see in that dark blue bar there. So again, overall, just shifts in utilization patterns really highlighted out. And one other key thing to note for that worsened, you will see probably the greatest percentage that is associated within the worsened category for metformin therapy alone, which is that light blue bar there. Okay, up on the next slide, it takes a look at Kaiser specifically in the treatment group distribution by the overall CCI risk here. And one thing that we did talk about was that regardless of risk, the majority of the members were on metformin therapy, and this really does highlight there. That overall light blue bar there is associated with the overall metformin therapy. This does include an overall number count. So as you can see here, majority of members were on metformin therapy. Within the overall higher risk, though, is where you do start to see an overall increase within not only GLP-1, but also SGLT2 utilization.
But this data is going to change, is what we just heard.
Yeah, exactly. To the point, it sounds like there's been overall changes there, so you can see expected shifts here moving forward.
I'll show a history, though.
Yeah, for sure.
I did think it was interesting. You could really see in this cut that the Kaiser historically before the change really was targeting the GLP-1 or reserving them for the more complicated patients.
Okay, and on the next slide, it looks at Kaiser specifically and changes in blood glucose control by the overall patient complexity, but more looking at it as a percent of the overall members. On the left, starting out, we have our overall low-risk CCI group. And one thing to note is that bright blue bar represents maintained there. So what you can kind of take from this is that within the overall low risk category, a majority of the members did maintain their A1C control across therapies. You can see it's much higher across each of the overall therapies. Within the moderate risk group, there was overall improvement in members within GLP-1 therapy, as you can see there, displayed within that DEF group there. And in the high risk group, the majority of members did improve on GLP-1 therapy while they only maintained on the other therapy. Okay, so next up we have the MODA results. And this is again looking at the treatment group distribution by the CCI risks. So overall, what you can see is that the largest percent of patients are on GLP-1s are actually within that low risk group, which really again highlights the overall differences in coverage criteria across each of the individual carriers. And on the next slide, just as we reviewed the results for Kaiser, similar display here for MODA again. Key take-home points would be across all three groups. The majority of the members were maintained, which is reflected by that royal blue bar there. And did see, I would say, proportionally more high risk did improve with GLP-1 therapy than with the overall low risk there. Next up, we have Providence. Again, treatment group distribution by CCI risk. Key thing here is that the largest percentage of patients on GLP-1s again are within that low risk group. Again, very similar results to MODA. And then next slide here, key take-home points would be across all three groups. The majority of patients did maintain, which is rather consistent with the other carriers. And within this one, I would say that we did see a higher percentage of patients that worsened on the SGLT2 in the high risk than we did see with the other carriers as well. I'm going to pause. Any questions? I realize this is a lot of data and a lot to digest. Okay, go ahead.
I have a question for you. I'm thinking about, I heard on maybe it's to Dr. Mueller, and I also saw that Dr. Popovich too was on remotely. But I heard on a podcast yesterday that only 40% of antidepressants are successful for patients because there's just so many factors that make medication effective. And it makes me think of the results for MODA and Providence where maybe I'm wrong, but I would assume the goal is not maintenance, especially when we consider the amount of money that we're paying for treatment. Like I assume the goal is improvement. But if in more than 50% of the cases, we are not achieving improvement, we're achieving even with the moderate and high risk, which seems concerning if we're only maintaining. And even by the time you add maintain and worsen together, and I guess the flip side of that is just to look at the black bar. There's like hardly any improvement at all, just about a quarter, like not even. So I'm just wondering if one of our clinicians could speak to how they see that. Maybe it's to Bill's point, HbA1c is one very small piece of the overall puzzle, and maybe health in other ways is improving. Or yeah, I'm just curious what we collectively think about that.
And Kirsten, I just wanted to add in too, and I definitely want them to weigh in, but also I think a lot of the maintainers, these might be the people that are already, a large portion of them might be the people that are already under 7%. So I think what we saw even in the, around half of people were already in control. We thought about trying to cut it an additional way too, but we already had so many slides, but that's something that we could take back if we wanted to dig in more. But if you think that of that 67% who maintained, I would guess a significant portion of those were already at -7, so maintain could be a good outcome there. We really wanted to focus on the improvement and seeing if there were differences in improvement across some of those drug groups. But your point's still taken, and I still would like Drs. Mueller and Popovich to weigh in on some of the other things that can affect treatment outcome.
Yeah, I think my initial thought is that what we really don't want to see is the same people applied to the same drug, we don't want to see the same number of people get better as got worse on a drug, right? That talks about patient selection. And so really, when I think about how I'm going to treat a patient, there are roles for some of these cheaper medications still, right? There are lots of people that can be controlled on metformin, glipizide, even a little bit of pioglitazone for insulin resistance. But there are certain patients that when they present to you, they already need help with weight loss. They may have fatty liver. They may have chronic kidney disease. That is a person that I would be much more interested in jumping to a GLP-1 and possibly the benefit of SGLT2. So that's how I think about it is each patient comes into you as an individual. We have to look at their overall risk factor and say, what makes sense for you to get you the best control as quick as we can? And what other comorbidities do you have that make that drug seem like the right choice in the right moment?
Your question makes me think that I have a misunderstanding of diabetes, right, at a fundamental level. I just assumed, maybe incorrectly, that your A1C and glucose numbers, if you wind up with diabetes, just continuously goes up until you die, right? And so that maintaining is actually a good thing because your natural progression is to constantly go up if you leave it untreated.
Correct. I tell patients all the time, this is a progressive condition.
Right.
Even if you work really hard, we have to follow it because your insulin resistance may go up. We may have to intensify your treatment.
And then that just causes more cost. But if we can flatline them at the best condition, if we can just keep them constant, that's a benefit.
Maintain that.
So that is the correct understanding then. I was questioning myself now based on your question. Right. So, okay, thanks. Flatline was probably a bad phrase there.
Right. We don't like that in medicine.
I'll improve my benevolence.
Evil eye.
Right.
Hi, this is Dr. Popovich. The only thing I would add to that is that it's hard to talk about improving here because these weren't patients new to therapy. They were on established therapy already. So measuring between the periods that people were in control didn't shift, showing that they didn't improve isn't really an accurate assessment of what's happening. And I'd also say that maintaining isn't necessarily bad, especially when you're talking about diabetics who have A1Cs, in the 7+ range. They're difficult to manage. And if we're maintaining, I don't see that as a negative. I think someone said that earlier, and I agree with that.
Yeah, I think you bring up some good, there were a lot of limitations in this data, and I think we knew that. At one point, someone had suggested doing like a regression model to evaluate it, but the data is such, to your point, some people may have initiated therapy during this period. Some of them may have been on established therapy for some time. We didn't bring in the adherence metrics here. There's just a lot of factors. So it's not telling the whole story, but we're hoping that this is information that gives just some touch points and, some different snapshots of what's going on over different time periods. Overall, we are seeing improvement in hemoglobin A1C. But we're also continuing to see people who are not in control. And it does appear that the portion of people who are in control does seem to be a little better for the GLP-1 utilizers, particularly for those highly complex patients, which speaks to, I think, what Dr. Mueller said earlier of, targeting those patients that have the comorbidities.
Yeah. I mean, it's certainly interesting data. I'm not saying it's bad data. I think, but it's definitely a reference point for us to keep moving forward with looking at this. I think it's great.
I think part of the challenge too is this is really kind of doing research in the wild.
Yeah.
Things that you can't control that you could control in a research study to measure things more formally. So I think we have to kind of keep that in mind as well.
And the next two slides just summarize the overall carrier data. Again, we've already touched upon several of these things here. Again, across all three groups, the largest volume of GLP-1 was within the low risk, as we already discussed. And then on the next slide, again, similar results to what we discussed is that across all three groups, the majority of patients did maintain. But we did have some conversation around that. That's not necessarily a bad thing. So at this point, I'll turn it over to Sarah to discuss next steps.
Okay, thanks. So yeah, so where do we go from here? This is a lot of data. Yeah, I think we have a little better understanding with this data, but I mean, as you're seeing, probably still more questions than answers. So where do we go from here? Certainly as we think about the work of SEOW over time, this may be a topic that we want to address again, knowing that there's been changes in treatment paradigms, both generally and then among the carriers. We know Kaiser has made changes to their treatment protocols, which could affect the distribution of treatment moving forward compared to the time period that we saw here. Some proposed immediate next steps that for discussion today. One is, and I believe this is included in the renewal letters, is asking the carriers, how can we improve collection of hemoglobin A1C data over time? We know from the data that we presented in December that there are gaps in collection of hemoglobin A1C. So this data only shows the people that have those measurements. There are people that are receiving these treatments that don't have these measurements, and there's a difference across the carriers. So how can the carriers propose to improve that collection over time? Also, asking the carriers to provide information and ideas on, somewhat to the question that was raised earlier, how can we ensure that the GLP-1s are being optimally prescribed so that the members are achieving improvement in their blood glucose control while balancing costs? So this is a new tool. It's a tool that works really well for a lot of people, and it's also a high cost tool. So what can be done to ensure that that tool is being deployed in the circumstances where it's most likely to generate significant clinical improvement for the member? So I wanted to pause there to see if there were comments, questions, or if there's other recommended next steps that the group would like us to explore. Robert has his hand up.
Jing, I am as far from an expert as anybody in this room could be. If we're going to do this long term, it'd be nice to, start off with people like me who are just below being pre-diabetic and then moving to pre-diabetic and then do a more longitudinal analysis. I don't know if that longitudinal analysis is decades or years, but to be able to see the effectiveness of different treatments from somebody who's just starting the journey would be valuable. I don't know if we can do it, but
that'd be a big study. Anybody else? I was thinking more on a broader scale that how often do we cover a basic blood panel for our people just to get an indication of where they stand in blood analysis of their overall health, right? And what do we do about that in coverage?
I don't know. I don't think that there are coverage limitations on that, Bill. We'll have to confirm, but it does not.
That, to get early data on our members, do we like you go get stabbed at the lab, right? Getting stabbed at the lab is awesome, right? Get a free Band-Aid, right? Something.
And then you find out how often your doctor's going to recommend you get stabbed again.
exactly.
I was just, because that's kind of the first step in preventative is just getting some blood numbers, just basic numbers on a CBC or whatever the right phrase is, right? That, that would then pull into the question of how do you determine whether the person should get an A1C measurement or not, right? Because you'd see sugar, you get your glucose number, you fast. You don't even need to fast anymore. They have numbers for that now. Yeah. But, as you know, for 9 years now, I've been like, how do you get people engaged into the medical community earlier, right? And their problems when they have a problem. Right.
I think it's interesting to think too that there's a new marker that is being studied that is going to come into clinical practice that will really give you a better idea based on 2 weeks of your blood sugars, rather than this is telling you what 3 months was. So we might be able to kind of move things faster based on control with those blood tests.
Which then, if there's nobody else with their hand up, since I have 2 pharmacy experts in the room, I want to go off topic just for the last minute. So there's a lot of data coming out, or at least news reports coming out, that GLP-1 studies showing as an anti-inflammatory usage. Is anybody looking at how that's going to affect insurance coverage coming out if that really gets approved? Because that's a major use model. Only seconded to hair growth for men. Right.
I know, and Nikki can weigh in here too, but I know Lilly in particular is doing some clinical trials, and they're expected to seek approval for their GLP-1 Zepbound in combination with Taltz, which is an inflammatory biologic, for, I think it's treatment of, sorry, I'm blanking, but it is an inflammatory, I think it's psoriasis.
Yeah, that's correct, Sarah.
Thank you. Thanks, Nathan. So yeah, it's for psoriasis with the thought of it's resolving both the inflammatory component of the obesity as well as the anti-inflammatory effect of that Taltz. Everybody is watching it. Yeah.
Huge push to pay for GLP-1s, right?
Yes.
That we should be aware of, right? So I just wanted to throw that down and, right. Thanks. All right. Anything else from anybody, including everybody, anybody online? Got comment, final thing? Andrea, how you doing? Right. You good? All right, with that, I'll call it for those of us in the room. You got till, for those of us in the room on OWEB, you have it till 1 o'clock. So we'll go grab some lunch somewhere, walk around. I'm showing like 60, 61 degrees outside. So thanks everybody. Otherwise I'll adjourn the meeting. Thank you, everybody.
Thank you. Well done.
Yeah, I didn't plan